certain versions. So just to realize that the ECG is not an act of sorcery or magic or anything. It's just spotting some cameras or leads or something that feel the electricity in different side of the heart. It just, you put your lead here and the machine sends the electricity, the direction of electricity, and the needle just draw the direction in the paper, and the paper moves in the machine. So I'll give you a drawing. So electricity comes to the septum first, okay, and there is a left and right bundle, and the left bundle is bigger usually because the left ventricle is bigger, and the right bundle is a little bit smaller, and that's why the electricity mainly in the septum moves from the left to right because this bundle is bigger, and then the electricity runs in the right ventricle and then runs to the left ventricle out of the bundles that runs beneath the endocardium. Okay, so electricity goes to the right, again to the right, and to the left, but the amount of electricity running in the septum and in the right atrium are small and small, but the amount of electricity running in the left ventricle, which is the big thick ventricle, is bigger. So if you put a camera or a spot or whatever here, so the electricity goes away, down, and then towards big up. Okay, if you put a lead to the right side, okay, so it comes towards up, and away, which is 3 down. So that's basically just to imagine how ECG works. We don't need to know this. That's just forget about it and go for the next. It's just, again, ECG is like putting cameras into the heart and looking to the direction and you know how big the electricity is going in this direction. So they just put some leads in the chest called V1, 2, 3, 4, 5, 6, and probably the V1 and 2 looks to the right side, the direction of the electricity coming from the right side or towards the right side, and V6, V5 and 6, the electricity going to the left side, and 3 and 4 and maybe 2, it's towards the anteriorly. Okay, so the direction coming anteriorly, and then they put a lead on the right arm, left arm, and left leg or whatever leg, and then they can measure the direction of electricity from right to left, or from right to down, or from left to down, and this we call them lead 1 and 2 and 3, or the pure direction of the electricity going down or towards the left and towards the right. Okay, so this is the direction in lead 1, the direction from right to left, the direction in lead 2 from 60 degrees on the horizontal line, and if you bought the lead 3, it will be like this, it will be like this. So this lead 1's direction is here, lead 2 the direction is here, which is the normal direction of the electricity of the heart, like that, and then lead 3 like this, and this is the lead going to the foot, really. Okay, so this is the normal direction of the electricity going towards lead 2, and that's why most of you'll see some stuff now, we look at them in lead 2. Normally we look at stuff in lead 2 because that's the normal, we presume that's the normal direction of electricity in the heart. But if the electricity going more towards the left side, we'll see the peak, which is going up in the lead, which mainly in the left side, which is lead 1, will go up. Okay, will be high, really, and the lead that goes mainly to the right side we'll consider that EVF, because that's to the left side, to lead 2, will go down if the electricity going mainly to the left side. Okay, if electricity going mainly to the right side, okay, so this axis is shifted to the right side, so the EVF peak the up peak will be high, and will be going away from the lead, which is going to the left side, which is lead 1. So it will be dip down. Anyway, I don't care about that. It's just about commenting the electrical axis, which is, we hear about it, but as a surgeon, okay, that's fine. It just indicate that which direction more electricity is going. Is it going more to left side or going more to right side? If it's going more to left side, that indicates that probably the left side is bigger, so it's having more electricity, or the right side is blocked. There is no electricity going to the right side, and the reverse. If it's going more to the right side, so that's probably the right side is bigger. Okay, there is right ventricular hypertrophy, for example, or the left side is blocked. There's something blocking the bundle in the left side. Okay, and how do you know it? Just look to lead 1 and EVF. Lead 1 and EVF in the ECG. If they are shaking hands, looking to each other, shaking hands, it's right axis deviation. We shake hands with right hands. So they're shaking hands, this is right axis deviation. If they're just not shaking hands, this is left axis deviation. And explained why this is happening. Left goes more to the left, which is 1. So the up will be in the 1, and the down will be in the AVF, and right to the down will be in 1 because going away, and up will be in AVF. That's how to comment on really the axis. Okay, this is some example for the axis. I don't care really about the axis. The components of ECG, we have the B wave, which indicate the electricity running in the atrium basically, and this bit of delay from the electricity starting from SA node running in the atrium, and then there's a bit of block here in the AV node because it blocks the electricity a bit, and then as soon as it goes to the bundle in the ventricle, starts to run very quickly in the bundles in the septum and in the both ventricles, the right and left bundle, and then we'll stop a bit, and then we'll have the this is the depolarization. QRS is a depolarization, and the ET is the repolarization of the ventricles. So that's the depolarization of the ventricles, and this is the repolarization of the ventricles. And this is just naming things. So BR is usually interval, goes wider and narrower. QRS is just look to the spikes, and ST segments, usually the abnormality in ST segments goes up and down. Okay, so how to analyze ECG? The most important thing, which is written in red compared to any previous ECGs. That's really important. That's the most important step, is to see if there is any differences or new changes in the new ECG you are doing now. Okay, that's number 1 and the most important one. And then you can go with a scheme really. Start with rhythm and rate, and we go rhythm before rate because it might be irregular, so that will affect how we calculate the rate. And then have a look at the axis. We discussed the axis, I'm not going to discuss it again. Have a look at B wave, BR interval, the QRS, and we comment on 3 things: duration, voltage, and if there is any pathological cue. And have a look at the ST segment and T wave. Rhythm, just check the RR distances, or the distances between the spikes in the ventricular electricity basically. If they're regular, that's fine. If they're irregular, if it is irregularity, so just erratic, they're all irregular, that's AF, atrial fibrillation. Okay, and in AF there will be absence of B waves. There is no electricity running regularly in a regular way or a normal way in the atrium, and that's why it's atrial fibrillation. Okay, and that's why there is no P. and if it is irregular, the other possibility is extrasystole, maybe extrapeat, ectopic peat. This might be atrial or ventricular. And how to differentiate between atrial extrapeat or ventricular extrapeat is the characteristic of the QRS. If the QRS the electricity running in the bundles, it will be rapid, okay, and that's why and that will indicate it's coming from the atrium, started from SA node to AV node, and running the bundles in the ventricle. So it will be normal and narrow, but if the QRS is bizarre and wide, that indicates that a single spot in the ventricles decided to take control of the heart electricity and started leading the heart electricity by sending electrical signal to run through the heart, but this will run through the ventricle in a slow way and a bizarre way, and the QRS will be abnormal. Okay, that's have a look at this. Do you see anything abnormal? Rate looks normal, regular, but here, have a look at here. That's definitely different than this, different than this, and different than this. All of these are different. That's AF. Okay, and here you can see a wide, bizarre QRS, which is ventricular extrasystole. That's wide, bizarre one, and have a bit of balls after it. And the atrial extrasystole have a P, and the QRS is narrow. Okay, is narrow. The QRS is narrow. Heart rate. How to calculate the heart rate? Normally, just to cut the story short, if the big squares from 3 to 5, that's normal. 3 big squares means 100 beat per minute. 5 big squares means 60 beat per minute between the big spikes in the ventricular electricity. Okay, the QRS complex, I mean, or space. A large square, normally the 5 millimeter equals 0.2 second. I don't care, I will forget that as soon as I finish this presentation. But what I care about that, if it is very irregular, I'll go for 30 big squares, and I'll count how many R's and multiply by 10. Okay, 30 big squares means 6 seconds, and multiply by 10, and then calculate the heart rate. That's in case of AF. But if it is regular, if it is 3 squares, tight, short distance, it's 100. If it is 5 squares, it's bigger, so slower a bit, so it's 60 beats. And that's the normal. The normal from 3 to 5 big squares between the big spikes. Okay, again, if we started here, if you just have one big square, that's 300 beat per minute, a lot. Very abnormal. If it is 2 squares, 150. 3 squares, normal now, it's 100. 4 square, 75. 5 square is 60. That's what I care about. If it is 3 to 5, that's normal-ish. Okay. Rate. Next, comment on the rate. If it is 60 to 100, the normal. 3 to 5 squares. 3 to 5 squares. So if it is more than 5, that's bradycardia. If it is 50 to 60, okay, that's probably sinus bradycardia. If it is less than 40, that's usually complete heart block, and I will speak about complete heart block. If it is 100 to 150, which is 2 to 3 big squares between the QRSs, that's a sinus tachycardia. If we started to get crazy, less than 2 big squares, and this is ventricular peats, which is wide, bizarre QRSs. I mean by wide, more than 3 small squares, but I'll speak about that later. That's a VTAC. This is ventricular tachycardia. If it is normal QRSs, That's SVT, supraventricular tachycardia, coming from the atrium basically. That's atrial beats, sharp, narrow, that's ventricular beat, bizarre and wide. As easy as that. And in these two occasions, in addition to that, if you have the seesaw sawtooth appearance of the B waves, a lot of B waves, and just regular QRSs, this is atrial flutter. In these three occasions, please call for help. Okay, just call for help. Okay, in these tachycardias, call for help. If it is less than two squares, two big squares, bizarre wide, I have VTAC, please come and help. If it is atrial, it's SVT, please, I need some help. If it is atrial flutter, please, I need some help as well. Okay, the next step is the B wave. Have a look at the B wave. Again, it's exactly how the electricity runs in the atrium really. If it is the B wave normally is 2 by 2 small squares, and you comment on it in lead 2. As I told you, lead 2 is the normal pathway of electricity of the heart. Okay, and if it is wide and broad and notched a bit, this is what we call P mitral, which indicate left atrial dilatation. So the broad one, left atrial dilatation. The tall one, tall peaked P wave, is P pulmonale. Okay, so mitral M, pulmonale, the tall one, which is right atrial dilatation. And you can see the P pulmonale and P mitral here. That's 3 small squares. BR interval starts from the beginning of P and indicates the amount of time that the electricity spent in the atrium, and the block that happen from there's a bit of delay and block happen in the AV node before the electricity goes to the heart. So it's normally 3 to 5 small squares. Okay, if it is bigger, that indicates what we call first degree heart block and other things. If it is shorter, it indicates maybe there is an accessory pathway, so the electricity skip the AV node by some way. The Wolf Parkinson White bundle, there is an extra bundle that can skip the AV node, or this can happen in sinus tachycardia, or the AV node took over and started the electricity, so there is no it just goes to the ventricle directly or without a lot of delays. Heart blocks. What is heart block? A few degrees of heart block. If it is the BR intervals are regular or irregular. If it is regular but the BR interval are more than 5 small squares, that's first degree heart block. Okay, if it is still regular but there is a failure of conduction of alternate B waves, but the BR intervals are normal and there is fixed drop beat like this, so P P P QRS P P P QRS P P P QRS. This is fixed P. After a number of P waves, you will have QRS. Okay, so this is what we call Mobitz Type Two. If the BR itself is irregular, that's one of two things. Either the P's are doing something completely different than what's happening in the ventricles, so the atrium is beating in a complete dissociation from the ventricle, and that's what we call complete heart block. Okay, so we'll find P's randomly scattered on the line here, and you'll find the ventricular beats coming every now and then, and this will be what we call the complete heart block. There is complete dissociation, okay, between the P waves and the QRSs. The Mobitz 1 or the wink path is regularly increasing BR. So BR is here small, getting longer, and then skip 1. So the BR is getting progressively longer and then skip 1 at some point. And that's why in complete heart block, the BRs in wink back, which is Mobitz Type 1, the BRs are irregular, okay, but in first degree heart block and Mobitz Type 2, the BRs are still regular, but in Mobitz Type 2 there is after few P's or no number of P's, the one skip. QRSs, I don't care which one called Q or R or S. I just look for the duration. If this prolonged, it's prolonged, which is more than 3 small squares. If the QRS wider than 3 small squares, that's not normal. If the QRS more than 3 small squares, that's not normal. And that indicates either bundle branch block or WPW. I will give an idea about it. Or ventricular tachycardia, it's a ventricular peat, okay, or hypokalemia, okay. So what is bundle branch block? Okay, bundle branch block, basically if the right bundle is blocked, okay, the electricity will run first to the left part of the heart and then run in the muscle to the right part, run in the muscle, not in the bundle. Run the muscle, and the electricity run in the muscle slowly, okay, not like the bundle just made for running electricity, but it runs in the muscle slowly, okay, and that will stretch a bit the duration of the QRS, so it will be more than 3 small squares. Basically, when I look at that, if you had a lock from the right side, okay, so electricity coming towards me, and then away from me going down, okay, and then towards me in a big bulk of muscle, so up and slow, okay. It looks like an M. So if you looked from the right side, it looks like M, the right branch block. When you look from the right side, which is V1, as I showed you in the beginning of the presentation, it looks like an M. So M in V1, right branch block. Very similar, M in V6, left branch block, left bundle branch block, okay. So M, something looks like an M in the right side, V1, right bundle branch block. V1 looks from the right side, V6 looks from the left side, and if you look wide, more than 3 small squares, looks like an M, it's left bundle branch block. Again, look to previous ECG. M, V6, left bundle branch block. Something looks like an M in V1, right bundle branch block. There are a few other criteria, but I don't care. A voltage, if the electricity going very up or very down, that means there's a big mass of muscle that runs electricity for, a lot of electricity basically. Okay, so left ventricular hypertrophy, if you found that the length of the electricity coming away from the left ventricle or down here in V1 is long, and coming to V6 up is long, if that's high and that's low. I mean, I know V1 is right side, V6 is left side. If that's high towards me, towards left, and that's low away from left, which is big seven large squares, that's left ventricular hypertrophy. And something very similar in right ventricular hypertrophy. If the R is bigger than the S in V1, okay, that means that the electricity is coming towards us more. So that's large, the right ventricle electricity is more than the left ventricle electricity. What's coming towards me is more than comes away from me. That indicates right ventricular hypertrophy. Basically, that's as easy as that. Again, that's the thing, how it looks like. And Q, I will go to the first slide really, or it's there somewhere. Yeah, a Q is as if you're putting a lead inside the heart. Okay, if you put a lead inside the heart, electricity you just as if you are opening a window inside the heart, really. Let me show it to you somewhere here. Yes, if you put that inside and you look to electricity, so it's coming away, so down, away again, down, and away again, so down and coming up. So as if there is a window inside the heart and you're putting the camera or the probe or whatever, sensing like electricity inside the heart. That's the cue that indicate that there is infarction in the heart. So Q indicates infarction. Okay, and wherever is this Q, will say where is the infarction. If it is in V1, that's lateral. In lead 2, 3, and AVF, as you've seen before, that's inferior. If it is 2, 3, and 4, that's anterior or septal. If it is V5 and 6, that's lateral. Okay, again, V5 and 6, that's lateral from here. That's anterior. That's anterior septal, and that's down. Okay, it's just looking to with camera to the heart, really. ST segment, again, if it's going up or down, that indicates ischemia. Ask for help. ST coming up, coming down, that's myocardial ischemia. Okay. T wave, again, it can indicate ischemia as well. So pathological T wave inversion can happen with hypertrophy, ischemia, or infarction. Okay, T wave abnormality, call for help. And compare to other ECG, other ECG. Is it new T wave change, or it's been there for a long time and we know about it? Okay. Again, these are the leads and what indicates which side of the heart is infarct. But anyway, ST wave, elevation, depression, this is as well has to be interpreted in addition to the patient presentation and symptoms, and in addition to troponin as well, because we all know that there is something called non-STEMI, okay, non-ST elevation, myocardial infarction. Okay, we need to know about that. So the troponin, clinical presentation, troponin, and ST elevation, and T wave changes. Again, where is the ischemia? You can decide from the ECG, and these are the cameras we're looking at. We just go for arrhythmias. Arrhythmias can be atrial, junctional. Atrial can be atrial ectopic beat, and we spoke about it. EF and atrial flutter. Junctional, SVT and Wolf, Parkinson White, which is just an extra bundle, which have the ECG will have short PR interval and slurred initial QRS called delta wave. That's the WPW. Ventricular, arrhythmias, premature beats, and we spoke about the wide QRS, the bizarre QRS, or ventricular tachycardia, and how fast it is. Is it more than 150, smaller than 2 squares, and VF as well, which is seesaw appearance. So and the heart block, the first degree, second degree, Mobitz 1, Mobitz 2, and the complete heart block, and the changes with the electrolytes. Okay, that's normal. Hypokalemia, increase that, push the T away. Hyperkalemia, push the T up. So hypokalemia, push the T down. Okay, let the T disappear and maybe have a U wave or something. Hyperkalemia, push the T up. Hypocalcemia, increase the QT. Hypercalcemia, decrease the QT. Okay, so that's how to look to ECG. Have a look at the rhythm first, and we know now how to do it. Rate, okay, and we know how to calculate the rate. 30 squares, how many deflection hours, basically, if it is EF, or just if it is regular. Have a look between the spikes of the ventricular electricity, and if it is from 3 to 5 big squares, that's fine. That's probably from 100 to 60 or 60 to 100. Axis, and was in the significant WAC axis. B, spoke about the B pulmonal and B mitral. PR intervals gets longer, shorter, gets regular, irregular, and what does it indicate? what degree of heart block, first degree, Mobitz 1, Mobitz 2, and complete heart block. QRS, speak about duration. If there's more than 3 small square, that's abnormal, that's wide. This might be ventricular beat, it might be heart block, bundle branch block. If it is right bundle branch block, look at the V1 or the right camera to the heart, you see the M. If it is left bundle branch block, look at V6, the camera from the left side, you'll see the M and wide. And then the voltage, if the spike is very high, that indicates that one of the ventricles is big. If this is towards the left side, this is left ventricular hypertrophy. If this is towards the right side, this is right ventricular hypertrophy. I spoke about the Q, pathological Q is as if you're putting a camera inside the heart and measuring the electricity. And ECT coming elevation, depression, and T-wave changes and ischemias and different parts of the heart. It's just few ECGs. The idea is to look, is that looks normal or abnormal? Shall I call for help? Not call for help? Shall I call for help? No. Do I need to call for help? Is that an AF? What's the cause of AF? Do I need to call for help? I think I'll call for help. Do you need to call for help? I'm not sure. Yeah, it is probably hypertrophy. Do you need to call for help? Definitely need to call for help. Okay, so that's basically in how to look to an ECG in 30 seconds for surgeons. Thank you.